Welcome everybody, welcome to this edition of EAUTV. It's Sunday here at the EAU and we've had a fantastic endourology morning with the plenary and then also a game changer session involving endourology. So we're going to discuss some of these themes that have come up this morning, and to do that I'm joined by two esteemed urologists, Joyce Baard from Amsterdam and Kari Tikkinen from Helsinki. So welcome.
Thank you.
Thank you.
So where should we start? Well, let's start at the very beginning, Joyce. So maybe we'll talk about, that was a talk on anticoagulation in endourology procedures and the difficulty with making decisions in that situation. And actually the theme was what to do if you just can't stop.
Yeah.
I suppose one of the things that surprised me was a message that actually it's safe to do ureteroscopy on these novel oral anticoagulants and NOACs. What are your thoughts on that? What's your practice?
Yeah, well, in the talk it was mentioned that ureteroscopy was considered a low risk for bleeding. I'm not sure if I agree with that. If we look at our practice, we try to stop with anticoagulation therapy. Except for aspirin, we have the policy that it's not necessary if patients really have an indication to use it to stop it. So we do surgery with aspirin, but all other anticoagulants we try to stop. And of course, sometimes you have these patients with, most of the time, a lot of comorbidities where the cardiologist says, really, you cannot stop, there's a high risk. And then we respect that. So I think in 95% of patients, we really stop with anticoagulants. But as we are a tertiary referral hospital, we have a lot of patients with a lot of comorbidity. And then sometimes we do ureteroscopy with the anticoagulation therapy, because you really do not have a choice.
So they stay on a novel oral anticoagulant?
Yes, they stay on it. Sometimes we bridge with something else, but if it's really not possible, we just continue. And it is a problem, because most of the time during surgery you do not have a problem, but once the patient starts bleeding, then it can be difficult.
Yes. And you lose vision and then you don't get to clear the stone.
But also post-operatively, if a patient has hematuria, it is difficult to manage. But yeah, it is what it is. It is reality, and in some patients we just cannot stop.
Yeah, sure.
Yeah.
And same question maybe to you, Kari. What's your practice regarding these anticoagulants?
It's very nice to continue after Joyce. I think she summarized nicely. I think the key is really understand what is the risk of thrombosis. What's the indication why the patient has, and then on the other hand, what procedure you are doing? What is it? Is it going to be a bloody procedure or not? Like and most of the time we stop direct oral anticoagulant for most patients. But as said, there are some indications. If you had a transient ischemic attack recently, you had a stroke, or you had a mechanical valve, you have a stent in your heart recently, or anything like that, you often must continue antithrombotic therapy somehow, either with what you have, or sometimes, although less nowadays, we sometimes bridge. Mm-hmm. But then on the other hand, if you have, in my practice, and if it's like aspirin for primary prevention, I try to stop it when I see the patient a couple of weeks before surgery, because I don't even see real indication. So then I just say for them that, okay, now you can stop it, and you can. So this is, I think, as she said, like it's all about like that. You know the patient, what somehow you try to estimate, and then you consult maybe hematology or cardiology, and then in these high risk patients, because they are the trickiest. But most patients we stop. Most urologic patients. We stop, and I because, for instance, if you just like atrial fibrillation without any other risk factors, stopping it for some days, couple of days before and starting post surgery, it's very small risk to get the stroke during that couple of days. Stop.
Yeah. It's all about indication, and also, of course, if it's not necessary to do that surgery at that time. Because some patients had a surgery and they have to be on anticoagulation for 6 months, and after that they can stop. And if it's possible, postpone your surgery. Be as safe as possible.
So low pulse stone.
This was excellent. This is excellent point. This is exactly, I agree. Like in stone surgery, for instance, if you had a stroke or TIA, I mean, you can just wait a little bit.
Yeah.
Okay, so that's high-risk patients. What about high-risk procedures? So say, let's talk about PCNL then. What's your practice? So in that, so NOACs, stop, for sure. Clopidogrel, stop. Aspirin?
We continue. If there's really an indication, we do almost all surgery. I think all surgery we do with aspirin. If there is an indication, as you said, if it's sometimes people take it where there's not really an indication, and then we discuss with the patient and give it back to the general practitioner. But otherwise, we do not have a problem with aspirin.
Yeah. So my practice has always been to stop aspirin.
Yeah.
So, and then we did this little survey in Baus Endourology, and it's actually quite split what people do. So there is no clear consensus on this, but my practice has always been to stop. So.
I mean, it's the indication really, and I know, for instance, in Finland, many people nowadays don't stop. They believe it doesn't make any difference in terms of bleeding. Trials show that it little bit increases, but it's so little that probably nobody can see in real life, because it's in your practice you can see. But of course it works. Aspirin works, so little bit it may increase. But so I think this is something you can kind of do either or with aspirin. But there are some patients, like those who had a stent for cardiac, like the coronary stent, you should not stop. They are you should use. But most patients, it's not that big deal, I would think.
And what helps, like in our hospital, we have very clear guidelines provided by the hospital for all types of surgery. So all trainees, all specialists, they can just look it up. It's a very clear guideline.
Yeah.
And that helps, I think, as well.
Yeah. And then the other thing we can do to help bleeding in PCNL is use tranexamic acid. There's now randomized data to say that reduces bleeding and reduces risk of transfusion. Again, it's not been my practice to use it. I think I consider our transfusion rates very low, and therefore the benefit of taking it is much more marginal. What about you, Kari? What do you think?
Yeah, that's a good question. I think it's kind of making a comeback. I know that most people don't use it. There is, however, in PCNL, more than 1,000 patients in randomized trial showing clear decrease in bleeding. But these PCNL trials are old, and they are not capable of showing if it increases thromboembolic events. And that's the concern which has been with tranexamic acid. However, there was 3 years ago in New England, there was a POISE-3 trial, 10,000 patients randomized, all sorts of surgeries. They didn't detect thromboembolic increase. Since that, I have been using when I do like endoscopic prostate surgery, for instance, or I recommend also like I don't use it for like a ureteroscopy, but a little bit like PCNL. I think now there's even this interrogation tranexamic coming. There's one trial on that which maybe had a little bit better, but it's unreliable. So I personally believe that it's coming back. I'm not that concerned about the clot retention as the older generation of urologists are, and what we will see. But I am a little bit concerned still about the thromboembolic events, and then if the epilepsy or spasms then I don't prescribe. I have seen patients having a spasm using tranexamic acid, so it has that side effect. So, but I think it's good for. Good to consider using it.
And Joyce, you laughed when we mentioned old-fashioned and clots. Maybe I'm old and old-fashioned now, but that's certainly been a concern of mine. I think we've probably all been trying to resect a very organised bladder clot for a patient who's been given tranexamic acid. Yeah. Is that not a concern with a procedure that is naturally causing hematuria? I mean,
that's a little bit the idea of tranexamic acid, that you because I'm not a biologist at all, but when there's a clot, like tranexamic acid prevents that the clot doesn't dilute, that it's there, and then it prevents more bleeding. So, but in these trials so far, it hasn't been a problem. It's something what experienced, and I value also experience, but I don't see any paper supporting that clot retention. I see a lot of talking about it.
Sure. So you use it, Joyce? One word, yes or no?
No, I don't use it.
You don't use it. Okay, brilliant. There's a clear take-home message. We're split in what we do.
Yeah.
Let's move on. Let's talk about your study, Kari, the APPEAL study. So this is a game changer presentation this morning. Very large. I'm not going to summarize it. You can summarize it. Very large randomized trial of shockwave lithotripsy and whether to give antimicrobial prophylaxis. with a positive outcome, I think, to this. So can you summarize that?
Yeah, thank you. So we had about 800 patients per arm, and we randomized patients. This is like a ureter stone or kidney stones, 3/4 kidney stone and quite many ureter stones, and then they randomized to ciprofloxacin or placebo. We were very blinded. We even were blinded after statistical analysis. We showed the team the results without telling which arm is which arm, but actually people were guessing right because you saw 0 events of infection in ciprofloxacin and 9 pyelonephritis. I'm talking about pyelonephritis urosepsis, which was the significant finding. So there was a 1% risk roughly of pyelonephritis urosepsis in the placebo, and then 0 in Cipro. Then there was about 3-4% risk of this bacteriuria or cystitis, and also that was the same trend, or like there was for instance 10 infections in the ciprofloxacin, urinary tract infections, and 20 in the placebo. So what we conclude from this, first of all, yes, antimicrobial prophylaxis likely decreases post-SVL infections. Yes, it works. But is it necessary? I mean,
that's the key question, isn't it?
So first of all, this is a trial. So we excluded struvite stones, those with nephrostome, and those with some other risk, like divers, anything like that. So the little bit higher risk patients are out. We included those with stent, and stent did not increase the risk, which is a little bit surprising. They have the same risk. So the conclusion, most people definitely, I think most people don't need, because 98 to 99% will do well do well with placebo. But there was 1% risk of pyelonephritis and urosepsis. So I think those should be detected, and somehow we should detect better the high-risk patients, because and then another conclusion which I like to make is that values and preferences, like that this is a value sensitive. What's like on one side it's a easy, cheap, which decreases the risk, but then on the other side there's this antimicrobial resistance, which can be a global huge problem. So we need to balance these things, and
the patient can't balance that, can they? We've got to balance that. And
they can a little bit. They can. I mean, we should always tell them. I think one of what the discussant Zafar was telling, that what he's thinking with this data would be that you wouldn't prescribe to anyone, but you would give some people maybe the prescription home, that the high risk patients, that you can just start the antibiotics if you get these symptoms. But that's also, the symptoms are difficult because stones can come from there, and you never know what is the infection and what is the without the trial.
Yeah, and I suppose just thinking, there's nine cases you had. I think just sketching it out, it's about NNT, and number needs to treat for about 80. So do you have any subgroup analysis where you might be able to go, these are the real group that you should target from this very large study?
So the second paper, which we have, which we will present hopefully next EAU meeting, we are working on it. So we are now is really looking for the key risk factors, but we will probably be a little bit underpowered, first of all, and this is a trial, so an observational prospective cohort study would be best, because we have excluded many people, high-risk patients from this trial. So if you want to really know your practice, this was pragmatic as much as you can, but the high risk are out. Yeah. So you should have a prospective new study where you look for if you could detect the key risk factors. We will do it with this data set, and it will be helpful, but even better will be without exclusion. But in trials, you need to exclude it. I mean, that happens.
We know the limitations of trials, don't we, I guess. Yeah. And one last question then. When it was being discussed, this question of what the definition of pyelonephritis meant and whether it just meant a fever. Yeah. Your face when that was said was a picture. What was your definition of pyelonephritis?
So it was a little bit maybe criticized that it was just a fever and bacteria. No. We actually, in a blinded way, we had an adjudication committee which looked every person who had a fever. We had a much more fever in these patients than 9. There was a flu, the most common reason actually, and COVID. They were the most common because this was partly during
COVID time.
During COVID time. So those fevers, mostly, but some patients are during that time. We didn't recruit much, but still there was a most of the fevers actually were not pyelonephritis. That these 9 were really educated, and actually many of them have even urosepsis. They had even the uropathogen in the blood, and then these about half, and another half was just that there was no other infection, no respiratory infection. There was a bacteriuria. There was a fever post procedure, and the clinician thought and hospitalized or started the antibiotics for the pyelonephritis. And sometimes you could even see it in the CT scan. There was signs of pyelonephritis. So sure. These 9 really are
true.
I think they very much are true. And we did it. I think one of the strengths of this study is that we did it before we unblinded. So I was part of that committee checking them, and I didn't have any idea which group this is.
Yeah. No, well done. I mean, it's a very powerful study. You know, you don't get much better than 1,700 patients randomized in endourology trials like this, trying to answer questions. So congratulations.
Thank you.
Right, I'm going to change subject again. I'm going to come to you, Joyce. I'm going to ask you about upper tract TCC.
Yeah.
So another topic, there was a panel discussion in the plenary, was a patient with a solitary kidney and a large low grade, so we know it's low grade, TCC. So this was more than 2 centimeters.
Yeah.
You know, so we obviously had a discussion about that, but how do you approach this in clinical practice?
Yeah, so I think this was a nice case because we know from the guidelines, there's not a lot of discussion. If you have patients with low-grade disease, low risk, then you should provide your patients or either discuss with your patient the kidney-sparing options. And if you have a high-risk or high-grade patients, then you should perform radical surgery. And in this case, solitary kidney, larger than 2 centimeters, imperative indication, what should you do? We know in these patients, when you perform a radical nephrectomy and these patients go into dialysis, the mortality rates in the first 2 months are really high, especially in the older patients. It's a bit age dependent, but above 65, the rates are really bad. So what I do in my practice is, if I have patients like this, have a clear discussion, an honest discussion with your patients. If you are really strict, if you look to the guidelines, radical nephrectomy is an option, but in imperative cases, we know we can also offer kidney-sparing surgery. So I discuss with my patients, we can do nothing. I think that's also an important one, especially with our older patients. Doing nothing and just accept is also an option. Or we go for radical nephrectomy, but then dialysis, and what are your perspectives then, and what is your quality of life? Or kidney-sparing surgery. And in our practice, that's most of the time with a lower pole tumor is ureteroscopy. We also discussed the role of percutaneous procedures. And I think in very selected cases, there's still an indication to do percutaneous procedures or percutaneous access for tumors. Yeah. But we do not often have the case where we cannot reach retrogradely tumor. So we will discuss ureteroscopy, laser ablation, and a good follow-up.
Yeah, so I think we all agreed, didn't we, that you'd always try with ureteroscopy first, but there were some very clear cases shown when that's not possible and that actually percutaneous surgery can be done.
Yeah.
So then the other aspect that was discussed is the use of mitomycin or mitogel maybe in the kidney. It's not something we have in Europe, not something we have in the United Kingdom, so I don't think any of us have any experience with that. But is that going to be a useful tool for the future? We use it in the bladder, don't we? Yeah. So why not use it in the kidney?
Yeah, there are some nice trials looking at the mitogel. Well, it's not available and it's very expensive. It's not available in Europe. But I have concerns about the adverse events, stricture rates, especially in those cases where you want to be kidney sparing. If there's a stricture, you cannot do your follow-up, and then, well, you've lost your kidney sparing approach.
Absolutely.
But as chemoablation, as I said, I do not often have patients where I cannot access the tumor and cannot perform a laser ablation. So, in my opinion, there isn't a possible role for additional therapy, but more as an adjuvant therapy, as we do with bladder tumors. Yeah. We do not have it yet, but I would position it more as an adjuvant treatment.
Okay.
Yeah.
And then we keep talking about laser and laser settings
Yeah.
with stones, don't we?
Yeah.
What about what choice of laser and laser settings in this situation? So if you've got all the options on your in your operating theatre in Amsterdam, which one are you choosing for this patient that we're talking about here?
So I must say we now have the thulium fiber laser. Before we had a Holmium, both do the work perfectly. But I do see some advantages with the thulium fiber laser. I do not have experience with other types of lasers. But especially the hemostatic effect of the thulium fiber laser is nice. So I see that it's not necessary to do a lot of stage procedures in larger tumors. We have a lot of patients with imperative indications sent to us, so sometimes larger tumors. And the thulium fiber laser, I think, is really nice because of that hemostatic effect. But those are the only two I have experience with. Yeah.
Okay, brilliant. Well, thank you very much.
Yeah.
I think we're probably out of time. So thank you very much to Joyce Baard and Kari Tikkinen. And thank you for watching this episode of EAUTV. Have a good rest of your day.
Thank you.